Hello everyone, it's Bill Code and Kristina back again for our Facebook Live. Oh, you found him. Very good light.
That was Denise.
Oh, well, there you go. We've got the advantage today. We have my wife's favorite light for sewing or quilting because it gives a nice natural light. Mm-hmm. So we'll get underway. Thank you for joining us. Of course, I'm Dr. Bill Code, and this is Kristina Mitz, my colleague. And Kristina has become very versant in many of the same issues we talk about, as well as a huge expertise within the microbiome. So she was our therapist for a couple of years, worked in our Taymont clinic in Canada, and that of course has been closed, but we're very fortunate she's working with me now and is now studying functional medicine. So following much of the similar path that I've been enthused about, along with my friends Dr. John Klein and Terry Jacklin. Terry is one of the authors in our book. This is great, thank you. So to talk about today, we said we were going to talk about the new MS, meaning microvascular syndrome. And to get to that, I want to open it up to you folks, because I'm sure there'll be some questions come in. And so please be patient and let us go through a few minutes discussion first, because that may help with some of the questions. And in addition, now is a good time if you want to share this with someone else. We've had a lot of shares in the last day or two. I was happily listed as a thought leader in the brain. Mm-hmm. So that's kind of exciting when it happens, because some of the concepts I'm going to talk about today, they're not accepted everywhere, and yet they are accepted in a lot of places. They're often accepted by pathologists, because they look very much at tissues of people with MS, and they're to a great degree accepted by many vascular or blood vessel interventionalists or interventionalist radiologists, and also by some cardiologists, and I'll be mentioning one of those today. And they're accepted by an increasing number of people with MS, and now with some clinicians that are experts in Meniere's disease. So we're going to talk about Meniere's disease in a future time, but it has some parallels, because it has some parallels with regard to the function of the microvessels in the brain. So the microvessels, just to set the template, are 5 to 100 microns in size. So 100 microns is 0.1 millimeters, so quite small. They're way too small to study in any individual fashion, and you certainly can't put a catheter down them because they're way too little. However, they're very key to providing a huge amount of oxygen and secondary to good blood flow required, especially in the brain and the heart, but also in the kidneys and other tissues that use a huge amount of energy for the function of their cells. And neurons are no exception beyond that. They need a huge amount of energy, produced, of course, in their mitochondria, by oxygen and a combination of some food substrate source, typically glucose or fatty acids. So as we start down the journey, I became aware of it, CCSVI, and started to follow that. And secondary to that, I had become involved in the International Society of Neurovascular Disease, or the ISNVD. And so I wanted to set that template, because that's how I do it in my book in the chapter 19, which is what we're addressing today, the new MS. So in that chapter 19, I talk about my trip to New York to the second, I think it was the second, it might have been the third meeting of the ISNVD Society, and it was fronted and coordinated by Dr. Salvatore Sclafani, who of course is an interventional radiologist in his own right. And he was able to tee it up, and one of the talks was from a major neurologist, a Dr. Mingar from Louisiana in the United States. And he talked very eloquently about all the pieces of MS, but it was still, in his words, unknown as to what the initial trigger was. Okay? So that degree of honesty was a good start. I bought his book at the conference, and of course it didn't have anything about the blood vessel supply, but I asked him, I was able to ask the first question in response to his talk, And my question was, could hypoxia be one of the triggering features? So he was fairly well read, and this is in, I believe, May 2016. And he said, well, it's interesting that you asked that, because in April of 2016, there was a paper by Desai, D-E-S-A-I, in the Annals of Neurology, talking about that very thing. They had developed a new MS model in a lab animal, and hypoxia was trigger, and it was also extra oxygen was one of the solutions. So that was very exciting to me, because everybody had always said that the model for MS is the experimental encephalitis model, which is very much based on the autoimmune principle, but they use infection agents to treat it. It's very interesting to note, as a sidelight, some years ago, they had shown that if you gave extra oxygen to these animals with EAE, which was the experimental encephalitis, they got better. So what does that tell us? It's a very interesting feature. So microvascular syndrome, I think, is a more appropriate term than MS. I didn't coin the term. It was coined initially by Professor James, who wrote Oxygen in the Brain. As you know, I'm a huge fan of his. I'm very blessed to have him as a friend and colleague. He lives in Dundee, Scotland, and he hasn't merged much during the COVID times, of course. So if we look seriously at the microvessels, then what is the problem within them? Well, the reality is there's a lot of data, and Professor James helped start this in 1983 when he published in The Lancet, which is a very decent journal, a case of MS occurring in a woman who'd had a mild injury, almost a blow on the shoulder sort of idea, and she died but when they did the autopsy, they confirmed there was fat emboli in the tiny regions of the brain where things trigger MS. So many of you with MS, or knowing someone with MS, will know that that's a region in the brain typically surrounding the ventricles within the brain. And it's here where the longest journey happens from the heart to these vessels. So the longer the journey through the vessels, down through the microvessels, then the lower and lower the oxygen. Okay? So that has been studied, and the other important thing to remember is that hypoxia presence within those vessels makes the endothelium, or the lining of the vessels, which is also the blood-brain barrier, very susceptible to injury. So one of the potential injuries, and remember, these are small vessels. They're sometimes, 3 to 5 microns. A red blood cell is 7 microns. Sorry. Not doing well with the numbers today. 7 microns, and they are 5 and above. So if the red blood cell has to squish through these, all well and good, okay? But if there is microemboli, so these are tiny emboli, so they may be of fat origin, they may be from hyperclotting origin, because some people with an MS diagnosis actually have Hughes syndrome, or in North America it's called antiphospholipid syndrome, so they've got hyperclotability. So they're benefited a lot by a blood thinner of a type. Warfarin has moved on, thank goodness, and they are on something else. But 15% of the population is hyperclotable. I'm probably in one of those groups. So I take regularly an enzyme, nattokinase, 100 milligrams twice a day, and I've been on that about 6 months. It's now, in a part of the literature, replaced aspirin, because cardiac aspirin or baby dose aspirin has now disappeared in the literature as a recommendation even for men, because it causes more problems than it creates benefits. Okay, so moving on, and then the third type of possible emboli is LPS, or lipopolysaccharide, which some of you will have heard the microbiome and the leaky gut talks earlier that Kristina and I did, and you can go back and look at them now on my website, drbillco.com. But lipopolysaccharide is part of a dead gram-negative cell bacterial wall, and it goes into little tiny amounts and circulates through the body. And anytime it contacts the outer lining of the cell in the body, it typically injures it and triggers inflammation. Because everybody agrees, even all the naysaying neurologists that don't look at a vascular cause, and remember, this was in the Annals of Neurology, probably one of the #1 things read by training neurology residents. So it was a huge step forward to have it published. Agree that MS is excess inflammation in a part of the brain, and it's a leaky blood-brain barrier. Okay, so we can still agree on that. We disagree on what the causes are. So one of the other features that's come to the fore, and I try to give a leaf of reference, I guess, to my neurology colleagues, because it's established that at least 15% of MS people have had microbleeds, so little tiny bleeds within the brain. And as most of you will know, iron, which is in hemoglobin, of course, in blood, outside the blood vessel is very irritating, very injurious, and triggers quite an inflammatory response. And it's quite well accepted. And when I had my major MRI down in Buffalo, New York, some years ago under Dr. Weinstock Gutman, they showed I had a lot of iron in my brain, which is now sometimes, and it's been suggested by Dr. Mark Hakey, maybe one useful way to diagnose MS, because it's blood outside the vessels. So did that happen from a microembolic injury? Okay, or did it happen sometimes from traumatic brain injury? Because in the hundreds of MS patients that I have seen and talked to, many of them, some of them will spontaneously say, my MS started after the car accident, after I fell off the horse, after I was in a motor vehicle accident where I had a concussion. Because traumatic brain injury is obviously sometimes a tearing of vessels. When torn vessels happen, they bleed. So you get a microbleed scenario. So what I'm trying to show is an olive leaf out to my neurology colleagues that sets up an inflammatory response, which has got the immune system involved. Okay? So there may be some pieces of what they've been trying desperately to confirm, that may be a piece of it. However, in the majority of cases, I would suggest it's a problem of microembolic origin or brain injury origin rather than a spontaneous microbleed, which makes sense for me. So as we move forward from that premise, I want to talk a bit about, as I do in the chapter, this is chapter 19, how there's a very strong association between cardiovascular disease and MS. So in a major study they did in the US and reported some years ago, there was, I think, 15,000 MS patients and 75,000 so-called normal patients. And this was done in the US military, so they had huge numbers. And they confirmed that people with MS had a 3.9 times incidence of stroke. And this has been shown up also in a Swedish study that MS people have more cardiovascular disease than the regular population. So we're back to a chicken and egg, which is the issue. But you need to be aware, if you have MS or care about someone who does, then you really need to focus, because anything that will help your MS will help reduce your risk of cardiovascular disease. Needless to say, any of us with MS do not want to have an added health challenge, such as a heart attack, heart failure, arrhythmia, or even a stroke. Okay? So from what you may have alluded from what I've already said is, a miniature stroke is a good parallel to MS, okay? Because it has many of the same issues. And just to reassure you about, the neurologists and their great enthusiasm that lymphocytes are always at an MS attack, well, it's not quite true. Because two things. First of all, any stroke has as many or more lymphocytes, white blood cells, supporting it in that localized area than in an MS lesion. In addition, you can have MS lesions. For example, would be optic neuritis in the eye, where there is no myelin, so it takes away that anti-myelin theory pretty dramatically, okay? And each of those, kind of as a cascade going on. So, important piece to remember, cardiovascular disease is frequently associated with MS and vice versa, all right? The initial impression you would have, and I had this one myself personally for years, I would have reduced cardiac risk because my stress was disappeared because I couldn't work anymore. Take away the stress, you don't take away all the stress because there's other issues going on, financial income and little things like that. But also, if you improve your cardiovascular risk features at the same time improving therefore the health of your blood vessels everywhere in the brain, you minimize the progress of your MS, you minimize your risk for dementia, because ordinarily people with MS have a double the risk of dementia. So that's part of what gets me out of the bed in the morning to go and exercise on my trike with my wife Denise, and it's her birthday today, but we went out and cycled anyway, okay? So exercise is a great way to maintain cardiovascular health and vascular health and keep your mobility going. So in my 24 years with MS, I was always not as enlightened, but I'm more enlightened now, and hence my passion in going in the book, because in the first couple of books I wrote about the autoimmune component of MS. Mm-hmm. And now I say that's time for the dustbin or garbage heap.
Right.
Yeah. So that's how I want to go to part of the premise. And the interesting thing, if you go on further in that article by Dr. Desai, so it was done in King's College. I should read the exact name because then it really matters. So the research was done by a well-recognized team at the world-class Queen Square, this is in London, Multiple Sclerosis Centre Council, of course in the UK. And it was funded by the Medical Research Council of the United Kingdom, the MS Society in the UK, and the National MS Society in the United States. And I suspect, and I do say this is one of the most important pieces of research that these areas have never funded, ever funded. And it's interesting, if you go back quite a few years, some of you have heard and studied about Tracy Putnam, who's a neurologist some 30 to 50 years ago. He came forward with this premise. And he was able to reproduce MS in dogs by injuring their veins in their neck. But he was kind of drummed out of existence and never was accepted again because he was off the ordinary path. Dr. Tracy Putnam, brilliant guy, probably should have got a Nobel Prize, frankly, but he didn't. And then it went on to be rediscovered to some degree by Dr. Franz Schelling, and I've been lucky enough to visit him in Austria. He saw much of the end of his medical career because of his same investment in the same vascular component for triggering MS, particularly veins and the drainage of veins. But he also enlightened me that there was 7 cases in the literature where blocked arteries, so vertebral arteries supplying the brain, would often go through a muscle in a very unusual, since birth scenario, and those went on to documented MS. And that's arterial injury. Because what's the common theme toward the veins not draining or the arteries not having enough flow? You still get reduced flow in the critical parts of the brain furthest from the heart, and you get hypoxia, injury, and MS lesions. Okay? So MS lesions, the number one, inflammation, and the number one cause in the body of inflammation is hypoxia, lack of oxygen. And just to dispel any of the naysayers that say, well, too much oxygen is bad, it causes reactive oxygen species, not true, unless it's an incredible amount of oxygen over an incredibly long time. And remember, my background's anesthesiology. Oxygen was my friend for a long time, still is, still my very best friend now, because I use it every night. Nasal specs, because we'll get to that in a minute, because I think that is the modern medical treatment for CCSVI, because unfortunately the surgical treatment hasn't continued to be done very many places. It's got a really tough lean against it by the medical authorities. So I don't see it coming back significantly anytime soon. And so we're going to talk more about oxygen therapy in another chapter, in another talk. And I know we're going to get on to some questions here in a moment. And if you've got any, we'll get to those in a moment. So now to the veins. CCSVI, chronic, cerebral, brain, spinal, venous insufficiency, meaning that the veins aren't working sufficiently well, okay? And the typical part of it, and that's, we'll open that collar today, because the usual blockage, as it was in me, the worst one is typically the left jugular vein, but also the right, and they have a valve in them just about the collarbone or clavicle. That's exactly where it is, and that's where the relative blockage was in me. So when Dr. Michael Arata treated me initially in 2010, he opened those veins up, and he opened up also the azygous vein, which means gooseneck, which is inside your chest in front of the spinal column. So you're unable to look at it with ultrasound, but you can do these with ultrasound. But you can, of course, see it with the dye during intravascular treatment, or at least diagnostic treatment, okay? And that was treated as well in me, and it made a profound difference, but a lot of the benefits, not all of them. My hands and feet were still warm, because that's a very classic sign. The way I look at it, the brain is starving for oxygen, and it knows to get more oxygen, it has to cause a vasoconstriction in the rest of the body. And this is so dramatic in causing it in the hands and feet that these people have cold hands and feet. So severe, many of them will wear socks to bed, okay? So what the body's trying to do with that vasoconstriction is to shunt more blood to the brain. The downside is, if the problem is a relatively blocked vein, I say relatively, if it was completely blocked, it would blow up like a football, okay? Which is what happens in some cancer patients where it's completely blocked, all right? So by opening that vein up, you make things flow through. So why does the blocked vein cause a problem? Well, as you can imagine, if you got flow relatively blocked, then there's some degree of back pressure, and the artery, like everybody else in the world, takes the path of least resistance. So it flows downhill and it flows elsewhere. So instead of going to the key part, which in this case is developing MS lesions, it goes another route. But if you open those veins up, as in my case initially by Dr. Arata, and then later on in 2017 by Dr. Salvatore Sclafani in Brooklyn, New York, then those open up those veins and the flow comes through. And Dr. Igor Petrov from Bulgaria, cardiologist, spoke at one of our Canadian Neurovascular Health Society meetings and very much confirmed this because he did testing above the jugular veins before he opened them. And what did he find? He found low oxygen saturation and hypercarbia or high CO2, which makes sense because if the blood isn't flowing through well, the CO2 removes well, but if it can't get to the heart, it's higher than normal because you've extracted more oxygen out of those vessels and you've got hypoxia, relatively low oxygen because of that. And then when he retested after he'd opened the veins up with the balloon angioplasty, they were completely normal. Normal oxygen flow amount in them, as well as normal CO2, okay? So this helps confirm the premise of why this is making a difference. But it also gives an important clue that I want you to listen to. And so I do a lot of hyperbaric oxygen. We're going to talk about that in detail in future times, and we have some a little bit in the past. But by giving extra oxygen, you're helping solve the same problem that was created here. The CO2 is not much problem in this kind of case because it's not that dramatic. High CO2 becomes an anesthetic. And if it's high enough long enough, you die, all right? However, this amount of CO2, not a problem. But the hypoxia being slightly down makes a huge difference, and by adding more oxygen at the front end, it's a bigger value. So by adding more oxygen to the end, the jugular vein is what drains the brain when you're laying flat, which is how most of us sleep, okay? Consequently, it's at night you need the extra oxygen. So what I typically suggest to a new MS patient, and this is additionally reinforced if they have headaches, which is a fairly common association with MS, is that they use nasal specs or nasal prongs, 3 liters a minute while they sleep at night. And that will provide enough oxygen that it may well rescue those injured or near to be injured cells. Now, most of those cells in the brain or anywhere in the body, even with a stroke, don't die. They get enough oxygen to be maintained being alive, and they become so-called sleeping or idling neurons because they don't have enough energy to function and act cognitively and do all their normal responses. But if you add that energy back, they recover. So that's the major piece. And in that article by Desai, where they initiated and they got MS symptoms by using LPS, which many of us could do with our leaky gut syndrome, and that's why healing your gut, and we'll talk a little bit about that with you in a minute to reinforce that. If you heal your leaky gut and get less of that LPS triggering inflammatory responses in the brain, you will improve, okay? At the same time, you need to somehow make a difference so that there's more oxygen available, and the healing will happen hyperbaric, or if you can't reach it, then an oxygen concentrator at home. So I think we now should, or do we have any questions so far?
We have one question. Lately I have cold feet and hands. What should I do?
Okay. Well, I don't know where you are in the journey of life, Anita. Do you happen to have...
She's had CCSVI.
Okay. So, and if it's recurred, it probably means that those vessels are blocked. So I'll let you in on a secret that many of you will not know. When we do coronary artery bypass graft surgery, okay, we take veins from the legs, although one time we take an artery from a different place and move it onto the heart, okay, internal memory. But anyway, we take veins from the legs and we bypass where the blocks is in the blood vessels of the heart. Bypass surgery. In reality, within 3 to 6 months, certainly within a year, every single one of those veins is blocked. So that's part of what's happening. We do a venous angioplasty up here. It may make a significant difference depending on your personal anatomy, but in many cases it will reblock or partially block. Therefore, your cold hands and feet will return. Now, as I've used oxygen at night continuously for the last 2 or 3 years, I don't have cold hands and cold feet at all anymore. And it's not just because I've got better gloves or anything else. I've been able to reverse that component because if the brain is starved for oxygen, remember, it tries to raise the pressure and raise the blood flow by shutting it down in the periphery. This is exactly the same as what happens when you're busy digesting a big meal. We don't have as much energy and power in our muscles of our arms and legs because it's being shunted primarily to the gut. At the same time, when you get anxious and start to run, you tend to get a shutdown of this flow to the skin, and it gets vasoconstricted because the body tries to deal with one thing at a time. But it's number one is the brain. So once the brain gets enough oxygen, it quits sending out that message to vasoconstrict through adrenaline and some other variation of the peripheral vessels, and they warm up. In fact, it's so severe, in my sister with MS, she had problems with pain in her wrists. And I learned from Dr. Weinstock Gutman, a very clever neurologist, she's at University of Buffalo, New York, was that this is a common entity in the chronic MS patients. They get arthritis in their joints, and it's mostly due to a lack of blood flow. Because remember, hypoxia triggers inflammation. What's arthritis? inflammation of the joint. Arthritis. Itis is just literally Latin for inflammation. So that's my suggestion, is you may be able to counteract those cold hands and feet, Anita, if you buy an oxygen concentrator, run it at 3 liters a minute at night. If you get MS symptoms and you can't get hyperbaric treatment, hyperbaric oxygen, then buy an oxygen non-rebreathing mask and use it for an hour, twice a day. When you get MS symptoms, just the same as when I get headaches, sit there and use it for an hour, and you will have dramatic benefit and response.
Anita would also like to know, where can she go to have this tested, as Sclafani does not do this testing anymore?
No, Dr. Sclafani, I think he may do a few cases. He can't do the testing in North America. It has become a very negative political football, tragically, in North America. And there's some of the interventional radiologists that did this had to literally pay people back because the insurance companies wanted their money back after the article came out by Dr. Trabulsi and others in Lancet, so-called eliminating the issue of CCSVI. And it was a suspect article, frankly, because they used a whole new way of measuring how much blood flow was going through the tube in the people that they tested. And this was done in Canada, I'm embarrassed to say, and people in my home province of Saskatchewan and my other home province, BC. But that's just the way the political ball is bounced. It's been discredited. So what I'm suggesting is a simpler modality. So getting testing for it, it's very tricky to do because no one properly tests veins for function and flow in this manner. I would suggest to you an alternate method, because this is how we diagnose some things in medicine, is how do you respond to the modality or treatment I'm recommending, okay? And if you respond to the modality and the modality isn't harmful to you, then more important is the diagnosis is that you've recovered. So I know the Holy Grail, because I've practiced medicine for 41 years now. The Holy Grail typically has been the diagnosis. MS diagnosis is only made by neurologists because they came out with the McDonald criteria some 15, 20 years ago. And it doesn't only work on the MRI. You must have 2 sets of symptoms spaced more than a month apart, okay? Or you can't have MS diagnosed officially by your neurologist. So once you appreciate that reality is reality, you may get a diagnosis of MS, but you're unlikely to get the venous studies done on an ultrasound on it because they say, well, there's no treatment for it anyway. The pendulum will eventually swing, and maybe it'll be a part of it. But the one reason I don't want you to spend all of your money and energies walking down the road of getting those veins treated, I've had it done twice. I probably won't go again because it recurred. Even though I got improvement even the second time, it didn't last as long. And like many things in medicine, it's the law of diminishing returns. Almost everybody gets less and less benefit every time they do it. And I know some people have had it 4 and 5 times, okay? So you can say all you want about people didn't know what they're doing, but I suspect they did, but I suspect it's recurring. Because remember, coronary bypass grafts almost all block up. So if you change your heart diet and lifestyle, you may well prevent another one happening, okay? So it makes a great deal of difference.
We have a couple more questions now, but I have a burning question.
Yes. Burning.
Okay, so the microemboli precede the hypoxia?
In most cases, yes.
Okay, and there's three types of emboli.
Right.
Okay, and so one of them is the LPS. Can you remind me the other 2?
It's miniature clots of the blood.
Okay.
And then the third one is fat emboli.
Okay.
So one source of fat emboli, I mean, a blow or an injury, to fat tissue, theoretically spanking a child triggers fat emboli, okay? But a blow to your arm, it doesn't have to be a very big fat emboli.
Mm-hmm.
The old classic way of thinking about fat emboli in medicine was in orthopedics. When you fractured a long bone, like your lower leg or your femur, there was all that bone marrow and fatty tissue within it, and that would travel through the body, usually to your lungs, and cause a pulmonary embolus and sometimes death if you're unlucky. But if it's very small, so that it's not filtered by the lungs, or if you have a patent foramen ovale, so it bypasses the lungs, which act as a filter, then it goes direct to the brain. So those 3 types of emboli is correct. But the other important part, the emboli do more injury if that blood vessel, in this case in that part of the brain, is relatively hypoxic. The more hypoxic a tissue is, the easier it is to injure it with an outside component. In this case, the blow of the embolus up against the wall. The wall is more vulnerable. It will have a leakiness produced easier, and the whole cascade occurs.
Okay. But then there's all of these other factors to consider that are also weakening the blood-brain barrier, weakening the vessels, like the nutrition and the...
Absolutely, because you want a healthy blood-brain barrier. But remember, because it's a way tougher to talk about something in the abstract, such as the blood-brain barrier. But if we say openly, and it is, the blood-brain barrier is the endothelium or lining of those tiny blood vessels throughout the brain, okay? So those blood vessels throughout the brain are in common with the blood vessels in the heart and throughout the body, so that any injury that's occurring to the vessels there can matter elsewhere. But it's especially a big problem. So it's an interesting sidelight, because I talked about the microbleeds, trying to give a way out to make the neurologist happy and contented and feel accepted. So Dr. Swank, who's a neurologist initially from Canada, but worked primarily in Oregon in the United States, and developed the Swank diet, which was very much on low fat, because one of his premises was MS people had very often little tiny microbleeds in their skin. And he said these people are having microbleeds. Part of the issue may be fat. And of course, if you've got a reduced fat in your diet, because there's some fats are not great for you. There's no question about it. The worst one of all by far is the trans fats. So when he started his diet in the 50s and 60s, we were just getting into the trans fats. And I suspect trans fats have aggravated the whole scenario. The other things that have been aggravated, as you well know, as we started to use more and more Roundup, we started to get more and more leaky gut. We started to get more LPS out of the leaky gut. And that again was a trigger for the problem in the brain.
Right.
Yeah. So we have another question over here.
I'll scroll back up, because there has been
2 or 3.
Actually, it was before this. Oh, the iron one. Okay. In regards to the iron buildup in the brain, is there any danger to taking extra iron supplements, or is iron supplements, are these something MS patients should take?
Well, it depends very much on the individual. Okay, so men hardly ever need iron supplementation. In fact, it may be injurious to it. I work hard when I take a multivitamin to take it without iron. And the multivitamins for seniors almost never have iron in them. And that's important, because too much iron is a real problem for the liver and other tissues, including the heart and brain, okay? So that part of iron. If you're actually anemic, and in women, of course, the more common thing is the monthly menstrual periods are very heavy. And one thing to remember, if you're in that 40s and 50s age range and you're getting really heavy periods, make sure you don't have hypothyroidism, because that aggravates the whole bleeding scenario dramatically. But if the iron ferritin, it's measured as being low, then iron supplements are a reasonable thing to do. But my favorite way of getting iron, red meat.
I have some tricks as well.
Good.
So for the most part, I don't recommend using iron supplements with my clients. I mean, granted, the majority of my clients are coming to me for gut and microbiome issues, and with the microbiome, a lot of pathogens like to steal your iron. So if you are taking iron supplements, well, you are just feeding into the growth of those pathogens. Okay. If you do take iron supplements, I usually recommend taking the food-based ones. There are plenty that are based on like chard and beets and that type of thing. But then there are also things you can take that help promote iron absorption from the food that you are eating. So for example, vitamin C can support your iron absorption and help you absorb it faster than potentially the pathogens can grab it. There's also another supplement called lactoferrin, which helps with iron absorption.
Sure. Okay, so you may need iron as a supplement if you're an MS person, if you're bleeding excessively or for some other reason, okay? But as a routine, it may not be the best idea, and especially in men, I wouldn't go there. So try to follow those. We get another question here. Okay, so this is a complicated question. I'm not sure. I'll try to address it, okay? It's by Elsick, and she's talking about, she's been diagnosed with MS, but this was speculated a while ago, and now she has a history of Lyme, which has been treated, but has now intermittent severe full flaccid muscle weakness presenting much more like myasthenia gravis, okay? Myasthenia gravis, of course, is an autoimmune disorder where the body is attacking the acetylcholine receptors, okay? So all of a sudden your muscles aren't working. These people can't, brush their hair, and they have such dropping of their eyelids, they look like they're asleep or they're only partly up because they don't have the muscle strength to lift them. And it's very commonly studied in anesthesia because there's a few drugs we use worsen it. And if you give a particular drug called acetylcholine, which blocks the acetylcholine receptor, instead of waking up or being ready to breathe again in 15-20 minutes, it may be 3 to 4 hours. All right? So we study it a lot. Myasthenia gravis has some treatment modalities, but if you can modify your entire well-being, through visiting someone like Kristina to get your microbiome and everything in order, you may be able to settle down your autoimmune disease quite reasonably and get it down under control, okay? So there is some crossover between Lyme and MS, and let me remind you, because I've seen a fair number of Lyme patients, Lyme is a spirochete, Borrelia, so it's a bacteria, and it loves to live where there's minimal oxygen. So in some people, that's in their joints, so they get terrible arthritis. They get the Lyme calmed down, they do better. In others, parts of the brain are short of oxygen. So you may end up with MS in that spot, or it may be aggravated with Lyme. The other thing about Lyme, and I spent a chapter on in the book, we're not there yet, but we'll get there. Chronic inflammatory response syndrome is a chronic inflammatory response initiated by Lyme, but now the Lyme is gone, you still got the inflammatory response. So it's a different modality, and this is the Shoemaker protocol. It's very well talked about in my book, but the chapter written by Dr. Karen Johnson, who works out of Hawaii and actually did medical school with me back in Saskatchewan some years ago. All right, so then there's individuals been recently diagnosed with chronic cranial instability as well, likely related to severe whiplash years ago. Could the chronic cranial instability trigger muscle weakness? And do you feel that there could be a lack of oxygenation as a result? I do, because the blood supply to the brain comes up through the carotid arteries and the vertebral arteries. So the vertebral arteries supply through the back of the head and on up through the system. They have the connection around the brain in most brains in the circle of Willis where the two systems meet, so that if one is injured, then the other one tries to take over. But it is possible from your recurrent whiplash that you may have cervical instability. And I would direct you to the chapter in the book where the chiropractor has talked about the specialist chiropractor in NUCA, National Upper Cervical Chiropractic Association, and treats C1 and C2 to enhance the positioning and improve the blood flow, thereby in many cases reducing headache, reducing hypertension, but also reducing, neck tension and muscle tension and TMJ tension. Then that can be a very useful component. And I believe it myself. We're going again, we go every 4 to 6 weeks to Dr. Sean Thomas nearby in Nanaimo. And he followed up the initial treatment I had from Dr. Gordon Hassick, who's one of the world experts on the treatment of the neck instability, because C1, C2 well-being matters for blood flow. And that's been documented and shown, even though not everybody accepts it. So we'll talk about it more when we get to that chapter. Sure. Okay. Yeah. Well, you're right, Anita. Neurologists were against CCI, and I'm glad that you were diagnosed properly, but it needs to do the other. So we've got another question here. This is from Sandra. Does nattokinase work the same as aspirin to reduce the risk of stroke and heart attack? And also, would it aggravate a stomach that has had a previous GI bleed? Well, that's an extremely good question because one of my passionate interests is in clotting of the blood. Okay. So aspirin works on the platelet, and it works for the life of the platelet. So if you take aspirin, then all the platelets, it'll take nearly 14 days for them to turn over and to become new. So that's why stopping aspirin 2 weeks before surgery, very critical. In fact, my surgeon, when I recently had surgery, which is associated with bleeding, of course, wanted me off aspirin for a month. No problem, because I don't take aspirin. I also, at his request, I stopped my nattokinase. Nattokinase is an enzyme derived from soy, hence the natto, and most of you soy stories or origin know about that. It acts on the fibrin. Okay, so the platelet clotting together and forming a platelet plug is one part of the clotting mechanism of the body. The other is the so-called intrinsic system, and that is dealing with fibrin and the buildup of fibrin. So about 15% of the population, and I would suggest it's a lot higher, and certainly it's higher in headaches, it's double that. So 30% of people with headaches have a problem with excess fibrin formation. All of us, when we have an illness, we make extra fibrin. It creates a bigger problem. Okay? So that's an important clue. And in the days of COVID, the long-term COVID cases are almost due to excess clotting. And that's why you get a stroke in a young person, you get kidney failure in a young person, and you get, sometimes liver problems, and even cardiac events in a young person, usually due to clotting and blocking in a vessel. Okay? Nattokinase tends to chew away and eat up the excess fibrin in the body. It still takes it back to the so-called bottom lower normal level and doesn't take it beyond that. So it's exceedingly safe. And I've been on it about 5-6 months now because this information came out early last spring that aspirin was no longer accepted as a useful thing for men to take because the benefits did not outweigh the risks. The risks are gastrointestinal bleed, brain bleeds, hematoma, all those sorts of issues. And so there was more people dying as a result of taking cardiac aspirin than were living because of it. I think nattokinase is a safer option. There is another one called lumbrokinase, but nattokinase is easier to reach in Canada by far, and 100 milligrams twice a day. And if you're anxious about COVID, it's a good choice to be on. Now, if you're a super bleeder, okay, maybe not, all right? It's probably not going to get you into trouble, but I don't add nattokinase, for example, to someone on a blood thinner, like warfarin or some of the other newer agents. So I like nattokinase because I think it's a safe way to go, and it's not just helping my brain vessels, it's helping my cardiac vessels and even my kidney vessels. So we'll talk a bit more about that when we get to hyperbaric oxygen, but I think it's a reasonable way to go for that hyperclotting. And now that we know about it, it would also be my choice in an individual who's going for CCSVI surgery, because typically they were put on for a month or two of a blood thinner of some description. Okay, Xarelto became the more popular one, although I know it's trade name, which it's generic name, which doesn't come to me at the minute. So nattokinase would reduce that fibrin formation and reduce the likelihood of injury occurring at the site. But remember, anytime you do a balloon angioplasty, you are stripping bare the lining of that vessel, and you're going to make it very prone to miniature clots forming, collagen change occurring, and all of the so-called scarring principles. You can't help it. If you take the inside of a vessel and blow up a balloon inside it, you will injure part of that vessel. You just can't help it. So what you're trying to do is have the benefits outweigh the downsides.
But would, for her, because she's had this prior gastric bleed, would it be?
It would not. It would be safe.
Okay.
It would be very safe, because the other downside of aspirin is it reduces stomach lining, the mucin layer, and it acts like all the non-steroidal anti-inflammatory drugs. It acts on the platelet as well. So they're not a good choice. They all have that downside of excessive bleeding. Nattokinase does not. Works on a different action. Works on the fiber.
Okay, lots of thank yous. Okay, here's one.
Okay, a major concussion, whiplash because of a car accident. Looking to prevent more damage. Headaches are turned down through meditation and exercise. Good. Not a pill guy. Cannabis use as well. That has helped. I've recommended, apparently, oxygen chambers. And there's more. Okay. Are there other techniques to prevent more damage? Anxious about aging. And so we should all be anxious about aging. I mean, what gets me out of bed to exercise, as I said before, is that fear of dementia in the future. How do you prevent dementia? You start 20 to 30 years earlier, because both vascular dementia and Alzheimer's, which is a type of vascular dementia, frankly, start 20 to 30 years earlier. And if you look at any of the literature now, that's documented and confirmed. So if you reverse the injury happening to the vessel, and I've got a lot talking about that in the nutrition chapter, the supplements chapter in my book, then you're able to reverse that. So other pieces that you would do, Dave, you could think about doing the 3 liters of oxygen at night, all right? Because that will improve your oxygenation of your brain at night. Because at night, the brain wants to get optimal blood flow, because it likes to do 2 things. During the deep stage of sleep, it does the cleanup. The brain squeezes itself like a sponge, and the toxins of the day leave. But if there's relative hypoxia, because now you're laying flat, worse if you've got central sleep apnea or obstructive sleep apnea or mixed, a combination of the both, then that oxygen boost of 3 liters a minute, nasal specs, will probably be enough to minimize those occurring and help reduce your long-term problems. So keep up with your exercise, keep up with your hyperbaric treatments, because you're treating traumatic brain injury, and those work. And they work definitely, and they'll improve your cognitive response. We'll talk more about the oxygen piece in the future, because it's one of the new age of regenerative medicine and anti-aging principles, which most of us are into, because we don't really want to be unwell. We want to be well, die suddenly.
Yeah. There is also a microbial profile that's associated with healthy aging. So if you're looking to feel vital as you age, focusing on the microbiome would be something beneficial as well.
That's right.
And then I think that you would probably agree, vitamin D levels and...
Exquisitely important.
Yeah.
Vitamin D is really important for blood vessel health. It's really important to prevent COVID. Vitamin D helps 2,000 of your genes, 2,000 turning the good ones on and not so good ones off. So it's one of our primary epigenetic factors. What's one that's even bigger? Oxygenation. Increased oxygen affects 8,000 of our genes. Okay? So it is a powerful epigenetic factor as well. So all of these come into play because each of them matter.
Would taking nattokinase be beneficial for everyone with MS?
I believe so. Okay? I didn't suggest it to everyone initially, so that's asked by Heather, but I think it would help virtually everyone. Okay? Some people with MS have been carefully looked at to make sure they don't have that clotting variation called the antiphospholipid syndrome, but initially described by a rheumatologist in the UK, Dr. Hughes. So it's called Hughes syndrome in Britain, but that's the downside of eponyms because they vary per country and not everybody means the same thing. So antiphospholipid syndrome, and those people, typically they're on a major blood thinner, but if they have fairly mild degree, maybe, I don't know for sure, but maybe they could cope by being on the nattokinase. The nattokinase is unlikely to aggravate them, but it just depends on where the hematologist sits on the whole question. Because typically those folks are under the care of a hematologist. And I've met several MS people around the world who have their MS due to that syndrome. They've got a variation in their clotting techniques.
How frequently would you recommend someone take it if they also use a soft-sided oxygen chamber?
I would stay with the same, 100 milligrams twice a day, okay? It's not a toxic event. You miss one, it's not the end of the world probably, but it lasts 8 to 12 hours in the body, so twice a day would be beneficial. I tend to take it at bedtime and when I get up in the morning with my thyroid replacement. It's maybe not ideal, but it works pretty well. And it's interesting because when I was taking the blood sample, you get a little square of paper, it's got 4 dots on it, and you're supposed to put a blood drop in each one. Well, I'm a disaster trying to do that. I can make the hole in my finger, it'll start to bleed, but by the time I get it down near the paper, it's quit, it's clotted. So I think I'm in that 15% of hyperclottable people, all right? In that 15% are all of those people that would benefit from nattokinase. And as I've been on nattokinase long term, and a couple of other things, which we'll talk about in future talks, I've even got control of my headaches now. So it took me 40 years to figure that out, but with the combination of things now, they're getting better. And of course, I add oxygen because it often helps headaches. So let me reiterate, if you have MS, nattokinase is probably a good idea. If you have MS and you can't get to a hyperbaric chamber because of where you live, or you can't afford or purchase a soft-sided oxygen chamber, buy an oxygen concentrator that does a minimum of 5 liters a minute. Buy an oxygen rebreathing mask. They're not very expensive. And when you get symptoms, sit down and use an hour of oxygen, okay? And I would do it twice a day, just on speculation, if you can, to breathing well, because, you can do it while you're, maybe not while you're sipping your coffee in the morning, but you can do it while you're reading your emails or your newspaper or your favorite novel. But take the time to treat yourself. Some of you will up the scale a little bit, and they'll do exercise while they're on that non-rebreathing mask, so-called exercise while oxygen training. And I don't do it when I cycle outside because I can't get a tube long enough for the oxygen unit, but I do it when I run on the elliptical inside in days of bad weather. I will use a 10 liters per minute, that oxygen flow unit, and I can run faster, farther, because I'm getting supplemental oxygen at the same time. So exercise opens blood vessels up because the body muscles need more oxygen flow because they need more oxygenation. Similarly, they opens the vessels in the brain. This is good for you. It's maybe one reason that exercise is the best option within medicine.
Will the nattokinase affect the gut flora? No.
No, a good question. And I don't know if there's enough in it to maybe be one of your 50 foods a week. Perhaps.
Potentially.
Yeah. It will support one particular team, likely.
What is the ideal dose for vitamin D?
You need to know what it does in you, okay? The minimum amount anybody talks about people for MS is 4,000 international units a day, which is 0.1 milligrams. But spend the dollars. Some places you can get vitamin D measured, but if you can't, spend the dollars and get it measured, because find out the dose that you're on. If you've been on it for a couple of months, it should be all stabilized. Get it measured, all right? That's exquisitely important this time of year in the Northern Hemisphere. I see Dean's on today. Hello, Dean in Australia. It's great to have you back. But up here, our days are getting shorter and shorter and shorter, and we have now reached, on the 27th of October, I'm sure there's no vitamin D making sunshine in our sunshine in Canada. So even if you go outside on a sunny day this time of year, naked or just with a bathing suit on, you will not tan because there is no significant ultraviolet rays in the sun. They're being blocked. They're closer, but they're being blocked by the long, low flow through the atmosphere of the rays, and so they're not working. But I take my vitamin D year-round. I learned once I started measuring my vitamin D, and I learned this from Dr. Ashton Embry when we met at the 1997 Complementary Medicine for MS meeting in Vancouver. to take 4,000 a day, and I found when I got mine measured, I needed 12,000. When I got my gluten problems sorted and got off gluten, I could get away with 7,000 units a day. Okay? So I can't say definitely what yours is. If you're in doubt, you know you can take 10,000 units a day for 6 months. That's safe. But what I'd suggest is get it measured with what you're on, and then you can make a reasonable guesstimate number to how much to up it. So if it's in the lower third, I would take it from 4,000 to 6,000, and you probably will be all right. But if you're below the lower third, I'd take a lot more.
Mm-hmm. I'll let you answer that one.
Oh, okay. Vitamin D, or is cholecalciferol effective? So cholecalciferol, the vitamin D I recommend is vitamin D3. Okay? Cholecalciferol tends to be vitamin D2, which has to go through another step in the body, and it isn't as directly useful. And studies show that you need twice as much of vitamin D2, and sometimes 4 times as much, and even the odd one says it's the same. But my strong belief is vitamin D3 is a better choice.
Would oxygen therapy help with my headaches? That's from Anita again.
Yeah, well, probably they would. And we're going to talk in detail about headaches in 2 sessions. Now, we're not around next week. My wife Denise and I are escaping to Puerto Vallarta, Mexico for a month. Well, we'll be back in early December and be working on things then. And then chapter 20 is a different topic. And then 21 is all about headaches. And headaches are pretty interesting. I'm sorry, our next talk is chapter 20 on headaches. And that will probably be the first Tuesday, 4 o'clock in December. Unless we get really ambitious and do one from the beach.
Martin is concerned about D3 toxicity.
Okay. So you're talking about the toxicity of vitamin D3. Well, and that's why we measure the toxicity amounts. So in Canadian units, the normal is typically quoted at somewhere between 80 and 200, okay? Just depends a little bit where you live, all right? And I've had mine come back at 300, and I don't worry about it. I just back off on my vitamin D. We get really anxious about it, Martin, when it gets up to 450, okay? So there's no reason for anybody to be up there, and you need a huge amount to create that, okay? So I don't worry about vitamin D toxicity triggering cholecalciferol, all right? Cholecalciferol in excess, you're completely correct, causes injury and damage and extra laying down of calcium in the whole scenario. Everything in moderation. You can kill yourself with too much water, literally, because you get low in sodium and you can die, okay? So moderation in everything, and that includes supplements and most foods. Mm-hmm. Yeah, more than one. But, you know, a reasonable concern, be concerned about it, and that's when people measure. They measure their calcium, their phosphorus, and they make sure, because you want to have that vitamin D in a range. Tragically, most provinces in Canada and a lot of states in the United States, they won't measure your vitamin D. They say, it's too expensive to do, just take a modest amount in supplement. I disagree vehemently. Vitamin D is a very useful tool because it affects 2,000 of your genes. It's a very good way to be anti-inflammatory. Once you're over 2,000 units a day, it becomes anti-inflammatory, and at the same time, it calms down every single autoimmune disease known to man, and it also helps the microbiome.
Mm-hmm.
Decidedly,
exactly,
right?
Yes. Well, it specifically helps with the gut barrier integrity. So, yeah, definitely. And if you're concerned about supplements, there are definitely food sources as well. You could try eating grass-fed liver or mushrooms do carry one of the varieties of D and
Vitamin D2.
Yeah. And then
Mushrooms do.
Yeah.
So, major
well, cod liver oil too, but then you have to be careful about
vegans use mushrooms because they have vitamin D2 in them.
Yeah.
Okay.
Oh, and then raw dairy, if you tolerate dairy.
If you tolerate
And
dairy.
it's good quality. Anita, when we know about the date and time for our next talk, we'll just make a post on Facebook.
We will.
Yeah, we'll have to see how much time you need to get ready when you get back from Mexico, and
That's right.
what's going to
We
come up
may
with
have,
quarantine.
if it's still a 2-week quarantine, we may have to do it from different sites.
Yeah.
Okay? I don't want to jeopardize Kristina by being in the quarantine issue, and I don't want to jeopardize my quarantine. I'm delighted that we can go down to Mexico, come back, and at this point in time, do a 2-week quarantine. It is up for grabs because I know they're starting in Calgary a test concept of people come back on a WestJet flight and they're tested for COVID. If they test negative, then they go home and not quarantine. If they test positive, of course, they quarantine. So maybe we'll inch forward here in British Columbia because we arrive back into Vancouver. We don't come by Calgary, and we'll see. But that's 4.5 weeks in the future. It's hard to look too far in the crystal ball of the future these days. So I think we're a little over time. So we're gonna call it to a close today. If you want this to be seen by someone, send them to my website, drbillcode.com, because Kristina will put it there on a YouTube option, and our other colleague Piper, she will make it available as an audio podcast so that you can follow up and watch this entity. And it's been great talking to you. It's always a very topical, because there's a lot of passions and emotions over the whole CCSVI issue. I don't think it's closed yet, but I think the likelihood of having a readily available surgical solution in venous angioplasty is not going to happen anytime soon. So look at the oxygen side of things, look at nattokinase for the blood clotting, get that gut integrity solved to reduce the other method, the LPS microemboli, and we'll talk about some of those again when we hit the issue of headaches, because just as a little foreshadowing, 55% of migraine headaches are microembolic. So put that in your pipe and smoke it. Have a great week, folks.
Okay, thanks so much. We'll see you soon.